I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. I'm excited to have as our guest today, Dr. Jacob Peterson, who is a family physician, but not just a family physician. I hate to use the term just anything. He has a really unique perspective on medicine and the delivery of healthcare. And I want to welcome you today, Jacob.
Thanks, Demetrio. Good to see you.
Good seeing you too. So why don't you introduce yourself to us? Tell us a little bit about your journey. Tell us a little bit about, where you went to med school, residency, etc.
Sure. So I'm a small town Nebraska kid, grew up on a ranch and farm, ended up going to eventually through the whole med school undergraduate process to the University of Nebraska, and graduated from that medical school right into the primary care program, which is a kind of a cool program we have where we do skip our fourth year of med school and basically do an extra year of residency. Most of my focus was in internal medicine, but ultimately board certified in family medicine, so I could go back out into the rural areas and do everything from taking care of prenatal and doing C-sections to colonoscopies and clinic and inpatient and the full spectrum of care that's required out in the rural Nebraska areas. Originally went into a traditional practice, private practice that was insurance-based, running both hospital and clinic. Really got tired of pushing people through like cattle is how I tell my current patients. Didn't like a system that required me to see 20 plus patients a day in order to pay all of the staff bills and also get a basic salary, an average salary for a family physician in rural Nebraska. And so after about 1.5 years, I was 100% sure, but ultimately 3 years after I got started with that, jumped ship from insurance-based world and went into direct primary care. In 2000, I guess it's been 2 years ago now, started my own practice in Grand Island, Nebraska. In between starting that practice and the old practice, I also became board certified in obesity medicine. So I help people diagnose the cause and the mechanism of why they're gaining weight abnormally and causing adverse health conditions, but still maintain about half primary care focus and half, obesity medicine specialist. Still do carpal tunnel surgeries and vasectomies and a lot of those procedures that are still needed. And the difference now is I can offer a very low cost to patients and much more efficient way of getting them in and getting them seen. So that's been my journey.
That's awesome. That's exciting. So tell me, what was kind of the straw that broke the camel's back? I mean, the vast majority of people that I know that go into direct care didn't come out of residency or fellowship and go straight into direct care. They went into a conventional model and then they just got fed up and decided to switch. What was that turning point for you?
Well, I guess I was introduced to the whole concept of direct primary care through Joel Besmer. He happened to come on rounds one day on internal medicine wards with one of his colleagues and friends. And he talked to me kind of about how it works in the model. And I said, that seems like a much more efficient way to have a patient get access to you, get cared for, and for you as a physician to care for them without all the extra hoops. Ultimately, direct primary care does have some upfront cost to start your own, and to start directly out with another. Usually your salaries can't be quite as competitive as the insurance-based world. And the other aspect is, there's some loan forgiveness programs that you have to be a Medicare provider in order to qualify for. So ultimately did that to get med school paid off. But once that was kind of the loans from that was paid off, it was kind of like, I'm really tired of this kind of model. And so decided to jump ship. And even though it was a big financial hit to do so, I'm way happier in this model and caring for people.
Sure. So when you talk about the things that you prefer about direct primary care versus an insurance-based model, what were some of those frustrations? What were some of the things that really kind of drove you bonkers in the insurance-based model?
Well, first and foremost was always patient care. I could not effectively care for someone in a 15-minute appointment slot. And 10 minutes of that had to be spent on electronic health record and insurance-based data entry that, honestly, I wasn't focusing on medicine or person at all. I was focusing on some other criteria just to get notes done and bills paid. The other frustrations were definitely price transparency. It really sucked every time a patient asked, well, how much is that test going to cost? I don't know. Versus now with my model, I can pull it up in a second and I can tell them, hey, this test is $5. And some of these tests that I've done, such as lipoprotein A or LP little a, that one can tell you a big change in how your risk is for heart disease, cardiovascular disease, stroke, some of the biggest killers in society. Yet when I tried to run that through my insurance-based clinic, it was $170. It cost me $10 to one time check this for a patient. And they now have a lifetime's worth of data to know I'm at high risk, immediate risk, low risk. And I know now how to care for myself based on that risk profile. So the other aspect that I really hated was I was spending more time answering prior authorizations for an insurance company on bogus stuff. My wife is also a physician, and she's now having some insurance companies even require prior authorizations for x-rays, basic x-rays. They were getting prior authorizations sent for $5 medications. And so to me, these insurance-based clinics and companies, are really getting hamstrung and not able to provide care because they can't get anything done. They wait weeks and weeks to get basic approvals, and it would have just been so much quicker and less cost to go direct and say, hey, let's go get the x-ray. It's $100, done.
Sure. Yeah. I mean, I think about, I think it was about 7 or 8 years ago, I ended up having to get an MRI of my shoulder. And this is when I was still working in an insurance-based model, and I was, working for the people that were ordering the MRI, right? And, I ended up paying, it was a $5,000 MRI, and I ended up paying $3,500 of it because the insurance company covered the other $1,500. And I thought to myself, wow, it's awesome to have such great insurance. They paid $1,500. That's $1,500 I didn't have to pay. And then, a few weeks later, I had this patient come in who told me about his shoulder MRI, which cost him $495 total. And I said, well, you must have amazing insurance. He goes, no, I didn't use my insurance. I paid cash across the street. And he showed me, he let me pull up his MRI report and his medical record. Same model machine, same radiologist who read the MRI. And for the privilege of using my insurance, I got to pay an additional $3,000 compared to what he did.
Absolutely. It's my mom just had this, and the local hospital charged $4,300 to get a knee MRI. And I was like, Mom, I could have got that for $390 cash, and you'd have the read back the next day.
Right.
Insurance-based model, she had to wait several weeks just to get it approved. And then even approved, you're still going to pay $4,000.
Right. Exactly. For the privilege of using your insurance.
Yes. Thank you for having me pay $24,000 premium a year to then pay another $10,000 before insurance even may cover stuff.
Exactly. So now, we talk about affordability when it comes to direct primary care and direct specialty care. We make it more accessible. We make it more affordable for the patient. But, you get to spend more time with your patients, and you're not charging as much per visit because you're not really making them pay per visit, right? So, are you working for free?
No, I mean, maybe technically for a certain amount of time until you build up your patient panel. Yes. But our model is basically, it's a monthly membership, $30 a month for kids, $60 for adults less than 40. And then between 40 and 50, it's $80 a month. Over 50, it's $100 a month. Visits are zero cost. You see me as many times as you want or as you need, and let's take care of you. You don't have an incentive to stay away from healthcare. That's one of the biggest hurdles I found with patients is, well, I'm going to wait and wait and wait until things are so bad that I can't wait, because I don't want to pay $300 to $500 just for the visit. And then who knows what it will cost if he does testing. My patients now have an incentive to get stuff taken care of quickly. What we do then is we do everything at wholesale cost. So our medicines, we have our own pharmacy, our lab that we send to LabCorp, and my procedures. They're all based off the cost of material, and I'm not making enough money to care about it. Just enough to cover licensure and fees associated with having those services, and then the material products. So what I always tell my patients is, it's disincentivized care. I have no reason to do anything extra to you other than what I think is going to help. Because the only way I get paid and I make anything to take home and buy bread and all the stuff I need is if I keep you happy and make you better. Because then you keep paying the monthly membership. So I really like how that's set up, where I have no incentive to do more to you. I only have incentive to care for you as best as I can, as quickly as I can.
Sure. So then, when we think about a conventional model, an insurance-based model, I mean, when you used to work in an insurance model, when I used to work in the insurance model, I mean, we would only get paid if the patient came in. So if the patient called up, let's say my office, and they said, you know what? You put in tubes 6 months ago in my ears, and now I got this stuff coming out of my ears. What do I do about it? I tell them, well, come in, right? In a direct care model, I can approach that differently. Talk about that a little bit.
Yeah, certainly there are a lot of things that can be diagnosed over the phone with history. The studies would say 85% of all medical problems can be diagnosed with just history, just talking to the patient. And really only 5 to 10% of the time does your physical exam aid that. And then another 5% of the time do tests, lab tests, radiology, get you the right diagnosis and treatment after that. And so one of the classic examples that I have in my area is a lot of farmers just got out of, several weeks of harvest. Every year their allergies kick up, even though we can put them on triple therapy and all the things that you need to, and they get a sinus infection. It does not take my degree to figure out I have a sinus infection. It's always in this sinus, doc. Happens every year. This is the antibiotic works. I've never had a reaction. And some of the farmers are so elated when they join my model because they're like, oh, okay, just pick up your antibiotic when you come to town to get gas or groceries or whatever. Wait, that's it? Yeah, let's care for you efficiently. I don't need to take you out of the field and make things cost more for you. And for me, I don't need to waste my time with something that takes me 5 minutes over the phone to bring you into clinic.
Right, exactly. And so in a conventional model, you the incentives are kind of set up for the patient to be sick, right? You don't get paid unless the patient is sick. And if the patient is healthy, well, then you don't make any money. How does that compare to what you do now?
Yeah, like I said, my only incentive is to keep you paying the monthly membership. You're only going to do that if you think I'm providing you quality work, I'm getting you to feel better, and then I don't have an incentive to do what the traditional healthcare system does with insurance model. The more you do procedures and cut on somebody, the more you get paid. The more you run labs and diagnose things, the more you prescribe medications, you get to bill higher levels. For me, if you don't need something, I can just tell you. And if you're not getting better with my plan, you're not going to come back. So the only way that I get paid is to make sure you are happy with the care you've been provided.
Sure. And so in the conventional model, you could think of what you do today as healthcare, because you want the patients to be healthy, because that's when you do the best from a business standpoint and when the patients do best from a satisfaction standpoint, as opposed to a conventional model where it's really sick care as opposed to health care, isn't it?
Absolutely. You get paid based off higher risk, higher acuity, higher amount of problems that you took care of. In this model, patients want to stay with you if you're making improvements. They're feeling better. Their labs are improving. They're showing that their diseases are being reversed. And so in this model, definitely the incentive is more on the patient getting better, because they don't want to keep coming to you if they're not getting better.
Right. Yeah. So let's talk about how you started up your practice. Like, how did you make that transition? What did that look like? And what were the things that you did to prepare? What were the things? Who did you need to convince that this was the right way to go?
And number one, you have to convince yourself first. It has to be something that you are really ready to put in the elbow grease and the work and the mental work. Getting outside your comfort zone as a physician and learning finance, business, how to communicate and network. It's not like traditional system where you just show up and patients will be, filtered into your schedule. You got to go out and find them and convince them that this model works. For me, I also had to convince the boss at home, the spouse, if she's not on board, it's not happening. And it didn't take long for her to be an insurance-based doctor too before she's like, yeah, you need to go set that up. What were the steps? So my curiosity first started in residency, and, just always keeping my finger on it, going through training, looking at a few articles or talking with some people doing it. Ultimately, I ended up joining another DPC and working with someone with the potential of taking over that practice, but it just didn't work out, and it worked better for me to move locations and set up my own. But, was able to learn a lot of things from that. There are several resources out there. The AAFP for us has some stuff on direct primary care. Elation Health, I believe, had a 32-page or something like that document with steps and checklists on how to start a direct primary care, everything from getting your business number, your EIN, your electronic identifying number, down to how do you set up legal, get your documents so that you have contracts and everything set in place, your standard patient agreements, figuring out an EMR and which ones are cost effective, which ones do people like. And this, once you start making those transitions to the granular details of how am I going to set this up and what kind of systems and products do I want to use, that becomes more of a community-based effort where you get a lot of help from others that are doing it already and have troubleshot through a lot of these problems, such as the Direct Primary Care Alliance and, what they offer from my specialty standpoint. I believe there's a Direct Specialty Care Alliance as well, or similar organization. And really getting to know some folks in there and some key leaders and, picking their brain and being very gracious to them when they give up so much of their time to help you. Direct Primary Care Frontiers, another great website where you can learn kind of some nuts and bolts and legal side of that and how to set up your practice and know which state you're allowed to have that kind of practice in. So lots of resources, but the key and most important, I think, is other people are doing it.
That's awesome. And so you had a lot of resources, you had a lot of mentors, it sounds like, people that kind of gave you advice and tips along the way. But even then, your practice is kind of a unique model. I mean, you've got elements of direct primary care, and then you've got elements of direct specialty care, with the obesity medicine. So how do you mesh those, not just from a medical standpoint, but from a business standpoint?
Yeah, that's something I went back and forth on multiple kind of different ways. How am I going to do it? And ultimately, what I decided for my model was for the direct primary care, it was those monthly membership prices. If you wanted me to do the obesity medicine consultation, which is a lot more time intensive, and you have to justify, the several thousands of dollars I paid to get board certified and trained in that. I decided to make it $150 a month. And, originally I was saying if you pay the $150 a month for a year, I'll back the price off to the primary care rate and continue providing the same service. Now I've got it down to 6 months with my practice growing. And, as I can afford more and more things based on patient volumes, then I can be even more generous with my prices and what I'm doing for folks. Because ultimately, when you're first setting up, you do have to pay the bills. You got a renter that's not going to let you stay in their building if you're not giving them their monthly rent check. But as things are continuing to improve and pick up, then I found that I can be even more generous with the kind of the offers I can give people.
Sure. Now, let me ask you this. If you had been in a conventional model, what do you think the likelihood is that you'd be able to branch out into these niches that, let's admit, obesity medicine is a pretty narrow or unique niche, certainly in rural America, but I would argue, in many parts of the country. How do you think that would have looked different? Would you have met any resistance from the administration if you were trying to do this in an insurance-based model?
Because I ultimately board certified in obesity medicine right before I left that practice, and they knew where I was pursuing this. And they were on board with me offering the service, but the problem with that is the billing side. Most insurances, especially at that time, they would not cover anything related to obesity. In fact, we even had some charts payments get denied for the visit because obesity was listed as a diagnosis, even though there was also heart failure and diabetes and everything, that had a comorbid disease that was partially due to that obesity and the same physiology. It got denied just because I had that diagnosis on the chart. So, yeah, that was another good factor for me, kind of pushing me towards this direct care model is, I can offer way better service, longer visit times, which is really what's needed when you're a specialist. You have to dissect a little bit more thoroughly and really get some of those fine details figured out on a certain disease. As you would know with your specialty, it's long appointments are necessary to really figure out specific causes. And that's what they're being sent to you for. They're being sent to you for a very niche expert opinion. And now I can do that, pay my bills, and do it a lot more efficiently for the patient and give them more quality access.
That's awesome. So then, when we think about a scenario like yours, where we're talking about direct primary care as well as direct specialty care, working side by side, again, that's a unique model, and I want to dive into this a little bit. In an insurance-based model, or let me rephrase the question: who do you work for in an insurance-based model versus in a direct care model?
So, in an insurance-based model, you are working basically for the insurance company. Because if you're not checking their boxes and meeting their standards, which, by the way, change, and they never tell you what those are, and you have to figure it out after the fact. It's a nice little thing they do so that they can somehow justify legally not paying you. Versus in this model, I'm 100% working for the patient. I have no other boss except the person sitting in front of me wanting care. There's nothing in between me and my patient now, versus there used to be several obstacles for a patient to get to me, and I worked for those obstacles until I was in front of the patient.
Right. Now, I can imagine that some of our listeners right now are thinking to themselves, and they're probably even screaming at their screen or whatever they're listening to this podcast on, saying, "No, wait a minute. I work in an insurance-based model, and my patients are my first priority. I take care of them first, regardless of what the insurance company says." But is that the reality in an insurance-based model? If you have to decide between what the insurance company wants you to do versus what your patient wants you to do, who has the final say in that case?
So here's how I would kind of reframe that is, yes, I think almost all or most physicians would say the patient is the first priority. Absolutely. No bones about that. And in an insurance-based model, they were my first priority. However, let's take a simple case of someone who has diabetes and heart failure. Gold standard medication for improving their overall quality, and especially if they have chronic kidney disease on top, GLP-1 agonists. Absolutely. Show me a study that says there's a better medication for someone right now who has insulin resistance, diabetes, heart failure, and chronic kidney disease. What do most insurances before, even when they were going through the process of saying these are much better quality for the patient, it takes about a year or two lag time before the insurance companies finally have to kick in and pay for those things. And even then, we signed a agreement so that this company's we would use, but not this company, Ozempic versus Trulicity versus blah, 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 blah. And you don't know that. They don't tell you that. You send it to the pharmacy. The patient calls you back saying, that's $1,300 a month. I can't take that. Okay. I don't disagree. Who can afford something that expensive? Well, they said if you use this one, it'd only be $100 a month. Really? That medication doesn't have the same improvement. And so for most Americans, I would argue, or most people, if it's $1,300 a month versus $5 a month or $100 a month, what do you think they're going to pick? People aren't made of money. And I actually, in my opinion, I think this is where insurance companies should actually be held accountable to Stark Law violation. There should be no financial incentive to anything. It is a decision between patient and doctor on what the right treatment is. You are a third-party payer. You get no treatment decisions. You get no payment decisions. If there is a problem that there is good evidence for using a certain treatment, then the patient should be entitled to at least pursue that option.
For sure. Absolutely. I think, we have cases. There are cases now. There was a case in somewhere on the East Coast. I think it was North Carolina. And there was a patient out there who had hip pain, and she had failed conservative care, and the insurance company refused to approve the MRI without another 6 weeks of physical therapy. And so they did the 6 weeks of physical therapy, and then it took another month after that to get the approval for the MRI. The patient finally got the MRI. Turns out the patient had an osteosarcoma. And based on the findings on the MRI, the osteosarcoma, if it had been found 3 months earlier when the physician originally wanted to do the MRI, it might have been curable. But at this stage, it was no longer, and it was palliative. And so the family sued the insurance company for practicing medicine without a license. And from what I understand, the family won.
Yeah. Honestly, if you want the insurance-based model of healthcare to change, I think that's what it's going to take, is people are going to have to start standing up for themselves and suing, or having organizations that help them financially overcome that legal fee burden, and start suing insurance companies for trying to practice medicine, for denying patients payment that they've signed contracts with that patient, that they will cover your expenses after a certain point. Doing things like submitting prior auths on basic stuff just to delay the process and ultimately hope to get out of a certain amount of payments. And the nice part, at least for me, where I'm at for my own practice and my own self, is I don't have to worry about that.
Sure.
Patient and I just come up with an agreement and take care of it.
Sure. Now, let me ask you this. This is a two-part question. When you talk to other physicians who don't do direct care, what are some of the biggest arguments that you get against making the switch? What's the pushback? And then what's the pushback you get from potential patients? What are the most common arguments? And then how do you address those?
Sure. I'll take providers first. And for providers, I think that's changed over time. It used to be, well, you're just cherry picking patients. And there are plenty of cases, not only of myself, but you talk to Dr. Vance Lassie, who's been taking care of any patient that walks into his door and does high quality care with conditions that most primary care offices wouldn't touch. And there's no cherry picking. Some of the sickest patients we have are those that are the ones who are down and out. They don't have jobs because they have medical conditions that won't allow them to. They don't have insurance. Whatever case you want to make for it, they're not cherry picked. Now the shift has become more from a physician standpoint. Arguments against it is, the setup and the cost and the trying to, work through those things to get it done. Because you spend, till your 30s or later going to med school and having a couple $100,000 in debt, well, your bills got to be paid. And it's, it takes time to build up a direct care model and to recruit patients to the point that it can actually pay your bills. So that's probably currently the biggest hurdle I have from physician is just the upfront cost and setup and time lag and not being able to afford it right out of the gate from med school and residency. From a patient standpoint, most of the hesitation I get is still, I need something in case of those catastrophic emergencies. But if you actually look at the granular data on how often does it happen that you get hospitalized in an ICU and have a $100,000 medical bill and those kind of things, it's very low risk. And so are you telling me paying $24,000 to $48,000 was the most recent I heard from a patient for their family to be insured on a $7,000 a year deductible plan is worth that? I can tell you most hospital problems, if you showed up and had to pay cash pay and you told them I don't have insurance, they could work with you to the point that you probably after 2 years at that $48,000 premium anyway, could have self-insured yourself for almost all of those catastrophic costs. And if it becomes really bad, things like you're permanently on a ventilator, you're completely disabled and all that, agreed that might be a big financial burden. But at that point, probably the finances are not going to be your biggest worry. It's whether or not you can survive day to day and what your family and your life looks like going forward.
Sure.
There's also other options. There's share plans that are much more affordable for a lot of people. And depending on your pre-existing conditions and which share plan you're going with, I have patients who can get for themselves a $500 uninsured amount or deductible in share plan terms for $110 to $170 a month. Fractions of the cost. For entire families, they can get it for anywhere from $300 to $700. And that's at the very low deductible of $500 instead of $5,000. It gets even lower rates. So there's a lot more options. I think we've just had a system set up to dupe people into paying high insurance premiums. And honestly, not to sound like a conspiracy theorist, but we also have a lot of governmental regulation. You look at employers over 50 employees, they have to provide some kind of insurance product or they get a heavy tax burden or penalty fee. So our system's kind of set up to support big insurance. And I think that kind of thing needs to change as well, which, comes from multiple people standing up and talking to your congressman, talking to your state congressman and your Senate and all our leadership and saying, this is something we want fair, equitable ways of getting these kind of products or more affordable options and less regulation that hamstring people for not having the expensive options.
For sure. So let me ask you this as we kind of finish up here today. You were a medical student. You were a resident way back when. A lot of our listeners are medical students, residents, people who are still in training or people who are fresh out of training. What do you wish you had known about direct care when you were in their shoes? What advice would you give them to those people who are listening, who are thinking to themselves, this is kind of intriguing. I might be interested in it. Convince me.
It's tough to say because I was pretty convinced before I came out. I just knew I had to get a certain amount of time and debt paid off before I was doing it. But I would say is if you have any interest at all, start looking at it from, some of the organizations like the American Academy of Family Physicians and their segments on direct primary care. Get involved with the Direct Primary Care Alliance and talking to some direct primary care doctors out there. Work with your rotations, your residency. Maybe they can set up an offsite rotation where you go to a direct specialist care or a direct primary care practice and spend a month rotation doing that. Maybe look at, the other aspects like the Elation Health and their document and getting kind of your ducks in a row for figuring out, is this something I can do? What kind of, put together if you're a nerd like me, put together your Excel spreadsheet on, hey, this is what XYZ costs in my area for rent, for utilities, for whatever, and just pencil it out. See what your bottom line is and what you'd have to do. And ultimately, if you end up wanting to do this and you're getting pretty serious about it, go to a conference, meet people. There's direct specialty and direct primary care conferences, free market medical association conferences. There's a few other organizations out there that are doing this and have gigantic conferences that you could get CME money if you have that or whatever, and do it. Go learn about it. And then start networking with people if you ultimately decide you want to do it, because it's not a one person out on your own. It's a big family of direct care persons between specialists and primary care, and we're all working together to try and improve this system for ourselves as physicians. But I think most of us have done it because we want better care for our patients, and we want to be able to do it but still have our own life with our own families.
Sure. So one final question. We got medical students, residents, as we mentioned before, who are looking for guidance. They're looking for mentorship. They're looking for advice. How do they find you? How do they reach you if they want to contact you to learn more?
I mean, me personally, I have a website with an office phone number. Get a hold of me. Absolutely. Demetrio, if someone, through the residencies or gets a hold of your podcast, you can give them my email and my contact info. I don't care. I'll talk to any of the physicians and help them. And that's how to get a hold of me personally. But like I said, you have multiple organizations out there like Direct Primary Care Alliance, Direct Specialty Care Alliances, Free Market Medical Association, Direct Primary Care Nation. There's a plethora if you can Google search. And I guarantee you, if you're smart enough to get through med school and residency, you can figure out how to do direct and primary or specialty care.
Awesome. What's your website?
VitalityFamilyHealthcare.com.
Awesome. Any other last words before we finish up here? Any other final thoughts?
No. Thank you for having me. Hopefully the information's helpful to whoever's listening or viewing, and hope you're doing well.
Awesome. Well, it was exciting having you on board. I love talking to direct care doctors about the parallel healthcare economy we're trying to build, and it was great having you share your story with us, Jacob. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.